Managing penetrating abdominal trauma. Let's talk through evidence-based strategies. Hey everyone, welcome back. Today, we're diving into how to manage penetrating injuries to the anterior abdominal wall. Yeah, we're talking stabbings, gunshots, and the tricky stuff that comes with them. We'll walk you through the essentials, backed by the latest from the Eastern Association for the Surgery of Trauma, EAST Guidelines. What exactly is the anterior abdominal wall? So, first things first, what do we mean by anterior abdominal wall? Picture this zone. Up top, it's your costal margins and xiphoid. On the sides, the anterior axillary lines. And down below, the pubic symphysis and inguinal ligaments. That's the area we're focusing on. First steps: evaluation and imaging. When someone comes in stable, meaning their vitals are good, local wound exploration, or LWE, is the name of the game. We want to know, did the injury go through the fascia or not? If the fascia is intact, you can usually chill. No further ob workup needed. But if the fascia is breached, then it's time for more tests, imaging, or possibly surgery. CT scans, with contrast, if necessary, are super useful here. They help us track the path of stab wounds, see what's going on inside, and decide if there's any real trouble brewing. Let's talk management. Stab wounds versus gunshot wounds. Stab wounds, SWs. If the patient's stable, there's no peritonitis, no hemodynamic instability, no evisceration, and the CT scan looks good, you can often avoid surgery and manage them non-operatively. But if they show signs of peritonitis, instability, or there's evisceration, especially organs poking out, then it's straight to the OR for a laparotomy. Gunshot wounds, GSWs. Most of the time, gunshots in the front of the abdomen mean you're heading for surgery. The risk is just too high for something being seriously wrong inside. That said, if the patient is stable and the CT scan doesn't show any peritoneal violation or major injuries, then you might be able to manage them without surgery. But that's a pretty select group. Evisceration. When organs show themselves. Omental evisceration. That's fat poking out. Used to always mean surgery. But now, if the patient's stable and there's no peritonitis, you might just reduce it and keep an eye on them. Bowel evisceration. Intestines coming out? That's almost always a ticket to the OR. Too risky to wait and see. Laparoscopy. The minimalist approach. Sometimes we use laparoscopy, small cameras and instruments, to check for tricky stuff, like diaphragmatic injuries in wounds that straddle the chest and belly, or when CT scans just aren't giving us the answers we need. Antibiotics. When and when not to use them. Here's the bottom line. If someone's going to the OR for a laparotomy, they should get prophylactic antibiotics. But for superficial wounds that don't go into the peritoneum, no need for routine antibiotics. Rapid-fire takeaways. If the fascia is penetrated, you need more evaluation. Stable stab wounds often don't need surgery. Imaging can guide you. Most gunshot wounds need laparotomy, but stable patients with clean imaging might be managed differently. Bowel evisceration? That's a surgical emergency. And that wraps up our quick guide to managing penetrating abdominal trauma. Remember, every patient's different, so stay curious, keep learning, and as always, keep it safe out there. It's the Everything Surgery Podcast. Dissect the extraordinary.